Welcome, one and all, to another episode of the EMS P.O.D. with Chief Randall. Today, I have another interesting guest, and we're going to have another progressive open discussion that not all people like to discuss. Um, Jonathon Feit is from Beyond Lucid Technologies, and we're going to have a conversation about something that I think you really need to hear. Jonathon, welcome.
Thank you. And anytime someone uses the word interesting when they intro me, like first of all, let's do set the bar low. Second of all, interesting in what way? Um,
Right,
but
the
it's a
OT.
pleasure to be here. One of the most amazing reflections to me is to think about how long ago you and I started chatting about the value of data and QA and your document model, which
Yeah.
really influenced my thinking about how to train, particularly firefighters, but really folks across this profession on how to organize their thoughts. So kudos to you. You have made an impact, certainly on those of us who care about data and information and quality. It's an honor to sit here and talk to you, as it's always been to have all our conversations over the years.
Well, I appreciate that. So let's get into it. So, Jonathon, where did you come from? I mean, how did you end up here?
How much time do we have again? Um, so the short-ish answer is like so many people that come into this profession, there is a personal angle. In our case, as an organization, there's really two personal angles. Me and my business partner, Chris Witt. Uh, our organization, Beyond Lucid Technologies, is the only tech company in our space that was founded by two non-clinician MBAs. So if I'm a business guy, I presume today we're going to talk about money and economics and finance and some things that I know about. But I'm a data geek, and back way back when, and by the way, I should say Chris is a genius. I mean, the stuff that he can do is incredible, even to me after all these years. We came into this on September 11th, 2001. I enlisted in the Army. Uh, it was a reaction to our country being attacked. But I was signing up to be a field medic. So 91 whiskey was actually my MOS. But I have Tourette syndrome. It turns out that Tourette syndrome and other neurological conditions and the United States Army don't quite see eye to eye because my eyes move all over the place. Um,
Mm-hmm.
but I was training to be a medic, and I got a chance to see kind of what a military medicine, austere medicine uh, environment looked like. When I got out, I wasn't there for very long, and disability and the Army don't really coincide very well. I was looking for other ways to serve. I had a bit of a strange career arc, took me into media and a bunch of other places. And then I really wanted to pursue my passion, which was the medical business. Right, I wanted to be back in that world, serving people. I'm fascinated by all things medicine, and particularly what technology can do. And so I ended up at business school, met my business partner, Chris Witt, who his father and sister had tragically been killed in a car crash about 2 years before business school.
Mm.
So that was really his why, was this idea that, we identified this was in a rural environment in New Mexico. Uh, the responders that arrived on scene, both ground and air, really did whatever they could to serve and save his family members. But there was limited ability to communicate what they were seeing. There was limited ability to know what they were getting into, and so we really, again, there's a lot more to this backstory. But we got together, and the idea was to try to plug some holes. We had talked to some folks who were very intimately involved uh, in diagnostics and therapeutics and wounds and trauma. And we started talking to them about ways that we could address the problems. And we ended up talking to one fellow from the Army, from the Environmental Medicine Command, who said, "We don't know enough about the patients to do therapeutics. Can you focus on the diagnostics?" And so we really started looking into the trauma triage process. Obviously, there's a lot of talk about this, including in your neck of the woods these days around whole blood, for example, drones and things like that. It's really
Mm.
fascinating to me because it sort of loops us back to where we started. Um, and what we found was really one critical statistic that's so relevant to even where we're going to go today in talking about community paramedicine and things like that, which is that about 50% of data captured in a pre-hospital environment is lost at each node of handoff in that process. So, and anecdotally, we've heard across the country this number can go up to 80%. So, if you think about if you're a first responder fire unit handing off to a transporting ambulance service, handing off to the hospital, maybe you've got an air transport in there. At every node, at every handoff, half the information is lost. It starts to make sense why there's so much restarting of care, right? When you arrive at the emergency department, why they basically say, I know that you're Chief Randell, maybe, not even sure that's really who you are, right? You use me as an example. It turns out that in Charlotte, North Carolina, there's a Jonathon Feit spelled with an AN at the end of his name instead of an ON. And so if you spelled my name the normal way, you would actually find somebody in that town, in their health information exchange, that's not me, right? And so without the ability to even confirm identity and what are your health challenges and what's your health history and what happened on the scene, right? There's a game of telephone. There is just a ton of information that gets lost. It leads to expense. It leads to wall times. It leads to errors, right? I mean, the most tragic example that keeps being brought to me are cases, for example, a child in the back seat during a car crash, right? Imagine if the car goes down in a ditch, parents are knocked out by the force of the crash. Um, fire rolls up on scene, EMS rolls up on scene, they extricate the child's crying but looks okay, and 6 hours later, the child's dead because nobody knew that child had hemophilia. Right. And so to us, those are the types of opportunities lost along the way where you could provide for better care, more efficient clinical operational service, and get people paid for the work that they're doing by closing those information gaps and being able to say, here's what you did, and here's how it served, and here's the impact that it had. And so that's really where we ended up. There's a lot of story to that, but our focus has really become and always been connecting the dots. We started out in the EPCR world because you had to have a record system. You had to have a core for the information to either be captured or to land in it. And over the years, we've just built on that in terms of interoperability, tracking of data, which is where community paramedicine comes in, or mobile integrated health, right? If I'm tracking Chief Randell and if I know that he was here and he's there now, and I've seen him 6 times in the last week, where has he gone? What's happened in between? Who else has he seen? Who does he need to see? Right? All of those pieces of data, it's really about identify the data, move the data, track the data. And now we're really focused on things like post-crash care, specialty care for patients with disabilities and special health needs, being able to put those data proactively in the hands of a responder. So when you're running your service and your crew rolls up, again, to a car in a ditch on a country road, wouldn't it be wild if they could know that this is you and this is what your kids look like, right? And if one of these kids is in the registry because they've got a special health need, I know that they've got an allergy to something, or I know what their blood type is, and I don't need to give them type O. I can give them type AB because we're in a shortage of type O blood right now. So if instead of type O blood, I save the type O units for someone I don't know because I know that Chief Randell is type AB, so I give him type AB. And so we're focused on that information continuum. And it really goes back all the way to our core, which was, car crash, military environment. What do you know about the person? What would you do if you knew? And so everything that we do all comes back to that. And MIH is so core to that conversation because the guiding principle of mobile integrated health, community paramedicine, whatever you want to call it, is can I know Chief Randell and his needs when I show up on scene, right? Because I've seen him before and I'm going to see him again. And so if I don't need to start from scratch every time, then I can start to string together an impact view of what I've done, how it's helped, and if I can show how it's helped, how I can get paid for that as well. That's kind of our organization and our mission in a nutshell.
So as we talk about a little bit more about the mobile integrated health, from my travels and readings and classes that I've taken, this has really blown up. And to me, early on, it started to feel I guess, sexy. Like, oh, this is something new. This could be cool, right? Let's try this. And they create a small program here and a small program there.
That's right.
And they pulled some things from the rural areas. We're talking the Idahos and the Wyoming areas, right? And then this thing kind of grew because they were really early in this process because of need. So now we have private services, municipalities, hospitals popping up with these different programs, and they start. And we have a couple of in Indiana here that are flourishing,
Sure.
but how do you sustain something like that, right? And so this is where the good patient care model turns into let's provide some preventative care, but the difficult piece is what makes it sustainable.
Uh, yes, but so let me take the last part that you said
All
and
right.
sort of blow it up a little bit. I would suggest it's a myth, and it's the preventative care part that you described.
Yeah.
So I think everything else you said is true, and I do think that we have a real problem or challenge in our profession where we don't have enough cross-pollination of ideas, right? And even when you do have, as you mentioned, people from Idaho or Wyoming or Wisconsin or Indiana talking to each other, it tends to be pretty brief. Maybe you're at a conference, maybe you read an article. Um, you tend to get the good, you don't tend to get the bad.
Right.
Am I right? I mean, no one wants to come up and say, "Hey, my
Right.
program sucks," right? Or my program died. So I think we do have some myth making that we need to talk about. But the part that I would really hone in on, where you say preventative care, and the reason is because I think it depends, and that's where the money flow conversation comes in like I don't know if I want to say like a wrecking ball, but maybe like a rhino that just ran through the door, right? Because the question that doesn't want to get answered is who loses if this program works, right? And this is a fundamental question to anyone who does innovation and entrepreneurship, right? If you're, again, you're an entrepreneur, so you understand this, right? If you are going to promote an innovation of any kind, you always have to ask the question, what's going on now, right? Why is the status quo either good enough or the only thing people do, or it's been around for a while, right? Inertia is a real thing. And there are lots of different models out there for doing things. So how did we end up here? And when programs suggest preventative care, for example, but they don't ask this hard question, who loses, they run the risk of actually being so effective that they get shut down. And we've seen that. There have been more than a few examples at this point of either municipal or hospital based programs that are so effective at keeping people out of the hospital that the hospital shuts them down, right? Because they are effectively taking money out of the mouth of that hospital.
Mm-hmm.
So the even the preventative care concept has an asterisk next to it, which is that what your community needs? But I'll use an example actually of rural America. So we know that there are at least a few community paramedicine programs that are trying to get off the ground in rural environments where a focus on preventative care may not actually be the priority. Um, some of these folks are very well cared for. What their issue is, again, I'm working on one of these right now for a Safe Streets program, one of these federal DOT initiatives around Safe Streets and Roads for All, is the individual who would be the subject of the CP program has some kind of chronic illness, and they were prescribed medications, for example, for uncontrolled diabetes or uncontrolled blood pressure or something along those lines. Maybe they have oxygen, right? Supplemental oxygen. They got COPD, uh, but they're under care. Right? That's fine. That's not the problem, right? But because they're in a rural environment, they don't have somebody available all the time. They're kind of in the middle of nowhere, and the nearest pharmacy is 20 miles away. That's not an unreasonable thing, right?
Right.
So if they need their pharmacist, their medication refill on the weekend, and the community paramedic in that community is working 8 to 6, Monday through Friday, which again, we know there are CP programs that do that. Um, that person needs their meds when they need their meds. So they're going to get in a car and they're going to drive 20 or 30 miles to the pharmacy. But that's bad because this person has a chronic illness that makes them vulnerable every mile that they're on the road, right? They're vulnerable to themselves, they're vulnerable to others. They have, what if their blood pressure drops or they're feeling really bad or they have a hyper or hypoglycemic event behind the wheel? And so the issue there is not preventative. The issue is much more nuanced. In fact, it's a question of, do I have access to the care that I need when I need it, right? So if
Right.
you go in that community and you say, I'm going to do a preventative care program and keep patients out of your ED, your critical access hospital may be desperate for every patient that they get, right? That happened. In fact, the New York Times did a strong focus on Idaho a couple years ago. And they were, I think it was a year or two ago, and they looked at how Idaho's small hospitals around the state were dying. They needed every single patient they could get. They couldn't find enough people. So as soon as you say I'm going to prevent this admission, you're actually threatening the livelihood of that local 5-bed ED, right? That serves another purpose. So we need to get to a more nuanced level. So this really comes down to say if you are in the big city, right? So let's say you're in Indianapolis, right? Indianapolis has a whole lot of people. I hear that Gary has some problems, right? So if you're in Gary, if you're in Indianapolis, if you're in a big city where you got a lot of trauma and you got a lot of patients who are coming there for STEMI and stroke and all kinds of stuff, right? Maybe preventative maintenance or preventative care, I should say, is a pressure valve that relieves some of the strain on those resources. But one size does not fit all. On the other hand, going back to that myth making, I'm going to take you all the way back to the beginning of my diatribe here, is I think one of the most damaging, there are a couple really damaging things that this profession likes to say about itself. The first is 140 years for the fire department, uninterrupted by progress, which, excuse my French, is complete bullshit. I mean, oh my God, I see some of the most unbelievable innovation coming out of fire departments and out of EMS agencies, right? And non-emergency medical service transport providers. There are all sorts of pockets of innovation, and every time we throw ourselves under the bus that way, it does damage. But another real one that affects here is that if you've seen one service, you've seen one service, and that's a crock. It's just not true. And so, for anyone who goes across jurisdictional line, you'll find that just like so many things, there's much more in common than there is apart, right? And there's a local nuance, perhaps, maybe having to do with a regulation or the specifics of the geography and the demographics involved, but you're talking about around the edges. So if you've got a 95% commonality, if you're in Plainfield, right? Was your
Yep.
service?
Yep. Yep.
Right? So if you're in Plainfield and you look at a program in Illinois, like one that I'm privileged to work with, is Mount Hope Funk Grove in the McLean, Illinois area. Small jurisdiction, large area, kind of far from it. It's like 40 minutes from the nearest town, but it's self-contained, but it's got access to resources and they have a highway running through, right? There's going to be overlap, right? It's not 100%, but it's enough that you can learn from each other. Whereas if you're in Plainfield and you try to say, I'm going to look at Dallas, Fort Worth, I'm going to look at MedStar's program. MedStar's program is so far away from everything that you would be doing in Plainfield that you end up with this weird sense of either no one was like me, or I have to look at the ones that are the big six, the big eight, the ones that you were mentioned, kind of get a lot of attention. And what I think we should be doing instead is connecting the dots in a much broader way to say, who is like me? And it turns out this is a big thing in healthcare. In fact, there are whole companies that have been funded that have gone, big money transactions called things like Patients Like Me, right? Where it's people saying, I live in the middle of wherever. I could be in Plainfield, I could be in Seattle, but I don't know the other person who has this type of cancer. Or I don't know another person who's had a stroke and now they can't walk. So how do we find each other? And this is a social problem that we have right now across healthcare, but in EMS and fire and mobile medicine in general, I think we do a real disservice because those resources are so limited. So if every department that wants to create an MIH type program thinks they have to start from scratch, or thinks that if they go to the NAMI HP conference, they're going to hear from 10 people, and those 10 people are the only options that there are out there, both of those are wrong. Right? We're beyond 31 flavors. We're at like 31,000 flavors at this point. And so the big question that I'm trying to solve, that's an intellectual, very passionate question, is how do you find each other? Right. And
Mhm.
so, we have a habit of fire talking to fire and EMS talking to EMS and CP talking to CP, even though that doesn't really mean anything yet. And nurses to nurses and docs to docs and all of these silos, when what we find is some of the most amazing programs are collaborative. And they may not look like any one, they look like a group. And so when you look at those groups, you tend to find it's the result of people coming together and saying, we're all solving these problems on our own. What would happen if we worked together? And that sounds really hokey. It sounds, kind of kumbaya. But the truth is, that's what the world is trying to get toward. And things like Safe Streets for All as an economic driver are really helping with that because they're putting financial incentives behind collaboration to the tune of 300% of available money. So there's a lot of organizations, getting insurance companies and municipalities and states and feds and associations, and they're saying, if you work together, we'll give you more money. Because otherwise we end up funding all these onesie, twosie little things that never scale. And we'd rather you come together and say, it doesn't matter what patch color you have. It doesn't matter whether you're public or private. Figure out how to collaborate, and we will give you plenty of money. Right? You're in Indiana. You've got Eskenazi Health. You've got Ascension. Right? We've got really big hospitals, really big payer groups, and they have a lot of money to throw at problems. What they don't have is money to throw at every tiny little community thinking they need to do it on their own. But there isn't a great forum for organizations to come together and collaborate and brainstorm without threatening, being without feeling threatened. I worked that. I mean, one of the first CP programs that we ever worked was in Carmel, Indiana. We worked with Carmel and Westfield. We worked that program for a couple of years. And it was a remarkable experience to see you had hospital at the table, you had the municipality at the table, you had multiple fire departments. One was very wealthy and one was definitely not. And they found ways to collaborate, and it was all about tell the story, get the data, be able to track that information. And this thing was funded for years. There was really no question of whether it was worth doing. So, but who would have heard about that? I mean, I don't know if you knew about that program. There's a lot of people, even in the Indianapolis, in the what's the freeway, the 20, what was it, 270?
465.
Whatever the loop, but goes around Indy.
Donut. Yep.
Right. So there are people in the loop that didn't know what was going on in Carmel, and that went on for years. So it's a real problem of lack of communication, which leads to replication, which leads to waste, and you never get to scale. So if people start working together and having their data be consistent across the services, all of a sudden they can show, hey, I took care of Chief Randall. I took care of Chief Randall. You took care of Chief Randall. Hey, how many organizations, fire EMS CP organizations in the state of Indiana, touch your health information exchange? I guarantee you it doesn't even fit on one hand.
Yeah.
So how do people know what each other is doing? And so it ends up leading to confusion and a lack of consistency and a lack of continuity and therefore a lack of money. That is solvable. And it is being solved all over the country right now. But the people who are doing it, like the people who are running for politics, by the way, so many of the people who are running for office are the people who are available to grab the microphone, right? And the people who are in the weeds doing the good work, the people who should be running for office are too busy to deal with it. And so we need to find ways to tell the success stories and let people get to tell us what you did, tell us what worked and failed, and let us find out how we can do the same thing or we can avoid the same pitfalls. And we are not doing that yet, by and large. That's okay. A long answer to a short question.
No, that's fine. So let's roll a little bit into the economics of it, right?
Yeah.
Because when you're creating these programs, you have this worker bee model, but there's no financial end game. So, if you would.
Yeah, so I think I tried to touch a little bit on that here in my previous 9 pages of response. Uh, but I have a catchphrase that I love, and I've seen some people want to come at me with pitchforks for saying this, but I'm right, so I'm going to say it again, which is community paramedicine is not a clinical program; it's a data program. Right? You, as a clinician, are the clinical program. Right? If someone calls you 911, or they call you 211, or they call you whatever the number is, right? You're going to come. The question is, do you know what their needs are or not? Right? If you roll hot to the scene, you are going to assess the scene, size up, figure out all the things that you do, and you're going to deliver care. If you show up in a scheduled fashion with an appointment, with their case file in front of you, and you're able to say, "Hey, chief, I understand that you're taking X amount of medication. How are you feeling today? Right? What's your story? How does this? Have you seen anyone since the last time we've seen each other? Right? Have you? Uh, how are you doing? How has the suggestions that I made worked out for you? Right? Each of those steps in the process, those examples I just gave you, are not accidental. They touch on things like med reconciliation. They touch on things like appointments that are non-reconciled to your profile, right? To your case history, your medical story, as some people like to call it. Right? They touch on the question of when I if I saw you if I see you once a week, right? Because that's our check-in period. Because some CP programs do that, right? They will check on you on a schedule once or twice a week. But what if I had a 911 call in between? And that 911 call may not even be directly related to the reason you're coming to see me, right? You're coming to see me because you want to make sure my oxygen is good, my weight is going in the right direction if I have CHF or COPD, right? Et cetera, et cetera, et cetera. But you see me on Tuesdays, and on Thursday or Friday or Saturday when you're not working, I got up, I have COPD, I went to answer the door because the mail came, and I fell over and I hit my head on. I had a hypoxic event. I hit my head on the corner of the table, and so there was a head trauma, and my life alert went off, right? And I saw this happen, by the way. So I use that example. I can't even make fun of them anymore. It was the most ridiculous ads ever, but I can't make fun of them because I've seen it save somebody's life because they were motionless on the floor for too long. It was, so now I had this hypoxic event, this head trauma, but by Tuesday, I had the bandage and I was discharged. And I assume, as the patient, that when you come to me, you know that because I went to the doctor and they use Epic, and, right? Epic connects to the state, and my doctor's office has it and all the things. And then you show up using an EPCR, or God help you, using a spreadsheet, right? Or a notebook. And you know nothing, none of it. So, how much disservice is that to everybody involved? So if we invert that model and we start saying, well, which of the pieces of your management of care do I do? The term of art, by the way, for anyone listening to this, is attribution. So how much of your care, how much of your system savings, how much of your improved outcome, how much of your access to care can be attributed to the agency itself? And for every attribution, there is a dollar figure, right? If the only thing that I'm doing is I'm picking up the phone and I'm checking on your meds and I'm calling your kids to give them an update and I'm calling your doctor to make sure they know that I checked on you and your weight did this and your electrolytes were that and your blood glucose was this, there's value to that, right? And that value can be attributed. That's called care navigation, right? Helping people put the dots together. There's a dollar figure to that. But if my need is I have a doctor's appointment and that doctor's appointment is on Monday and I see you on Tuesday, right? And because you are vulnerable on the roads, right? You're visually impaired, you have these uncontrolled chronic issues, maybe you don't have a ride, right? You can't drive anymore. They took away your license. So if you don't have a ride, you don't have someone who's available to take you, and you don't know how to use Uber or Lyft, or you don't have a phone because you're a low-income person who has a button press phone, not a smartphone, right? So you don't have the ability to call an Uber or Lyft. You might miss that appointment. Would you know that missed appointments are a multi-billion-dollar problem for the U.S. healthcare system? So if the only thing that you do as a community paramedic is go to this person's home, go to my home, if I'm the patient, and drive me to my appointment, there's a dollar figure affixed to that. But that dollar figure is not just the ride and the appointment, it's the downstream effect of being better because you made your appointment, right? And your medications were correct, or your medications were changed, right? If you have a polychronic patient who's got COPD and CHF and a deficiency of whatever and a diabetes, right? They got the bag of pills. The there is a whole business model, a very lucrative business model. By the way, I know I have a friend of mine who actually created a whole company around this to make sure that you are dispensed the appropriate medication. Because if you're visually impaired, or the scoring on the pill isn't obvious to you, and you take the wrong pill, you end up in an ambulance, right? There was a CP program down in Texas, that Harris County Emergency Service District number 48, just to be specific, that cited an example of this in their service where someone was administered blood pressure medication. And the medication said take twice a day. But the medication, the pharmacist didn't tell them that twice a day is separate. So they took two pills at the same time. And then this woman walked herself normally. She's fine, right? She walks herself up the stairs carrying the laundry, has her blood pressure crashes, and she rolls backwards down the stairs. And now she's got neck trauma and a whole physical therapy, right? What's the cost of that, right? So that's not even preventative. That's just making sure you understand how your medications are supposed to be taken, right? The prevention couldn't have been foreseen. You didn't know she was going to fall down. You just knew that, like when you have a kid and the nurse comes to your house a week later and says, hey, by the way, do you know how to change a diaper, right? You're going in and you're making sure that you don't have a problem. It's not even preventative. It's just education, right? And it turns out there's a dollar figure to that. Guess what? What if it turns out that part of your problem is that you don't have the ability to manage your own health because you have a special health needs child or a special health needs parent, right? Last night, not the state, not too far from you, I was watching the Democratic National Convention, and Governor Whitmer from Michigan, right, was talking about how she's a sandwich generation, right? She was taking care of her kids and taking care of her parents, right? So what gives, right? What gets missed along the way? So if it turns out that you have a special health needs kid, so you can't take care of X, Y, or Z, what maybe needs to happen is that someone comes to your house and helps you with some homeschooling. Make sure that the food gets made. Guess what? If that kid is now healthy because someone came and helped, there's a dollar value to be fixed to that. And that's not imaginary. One of the wonderfully funded programs in Colorado, which is one that I've worked with for years, Delta County Ambulance District, is, as they will tell you, very handsomely paid by a division of United Health for their work. And one of the most compelling stories that they have to tell is of a child who had Duchenne muscular dystrophy in the community. And they got special permission to be able to provide infusions in the home. But when I talked to the mother of this child, her concern was not the fact that her kid was able to get infusions in the home. He was getting care anyway, but they had to drive 4 hours to Denver from Delta County. And the impact was not on her child with Duchenne's, it was on her other kids. And the one thing she said when I asked, what would you want to tell Delta County Ambulance District? So I get a chill every time I tell the story. Is thank you for letting me be a mother to my other kids, right? Because she could be around. So think about the economic value. Now she can hold a job. Now they do better in school. Now she doesn't have to go and spend the gas money, a couple times a month to go back and forth to Denver. She doesn't have to get a hotel. She doesn't have to brave the freeway during the winter, right? All of these pieces of value that Delta County was able to measure and then present to their insurance companies and present to the PACE program, present to the area agency on aging. All of these organizations that have a ton of money, but the story is super granular, right? It's not just, hey, we had a kid and we got this kid infusions. That's great. But the value proposition wasn't even on that child. It was on the other children, right?
Wow.
And so when you take the economics and you look at it with a broader aperture, our profession is looking for the easy win, right? They're looking for the idea that you have COPD or you have heart disease, you have whatever it is. So I'm going to come check on you, or I'm not going to have you be in readmission, right? We can talk if you want all about the readmission error. There's a fundamental mistake that our profession has. Again, another myth that hospitals don't get paid if you get a readmission. That's just not true. In fact, they get a discount. Like the amount they get is haircut by a maximum of 3%. And that doesn't even apply in Maryland. There is no penalty in Maryland. So it really depends on where you are. But we've got this myth. What we should be doing is following the money, right? And again, like any entrepreneur, I can say to you, you would ask somebody, if you're going to pay for my services, right? If you're going to pay for my program, you're going to pay for my tech, right? You should be able to say, this is the value that you're going to get out of it. Better clinical performance, better operational performance, better financial performance, right? Better retention of your people, right? Better peace of mind, right? Less burnout, right? All the different things, right? It's going to make us more attractive, more competitive as service. When it comes to CP, people don't want to do that. They're looking for the easy win. When it turns out that the easy win may be the lowest value of all the possible wins. So when they start to open the aperture, they find that there are colors of money all over the place. But it requires understanding things like, what is an actuarial table? Right? How does risk factor into things? If you are a firefighter or a medic or a cop, right, who goes into the home of a mentally ill individual who may be violent with you, right? You're trained for that, right? If you are a home health nurse who got assigned a patient who may be violent with you, that's not in your normal job description. You may not know what to do, and the home health nursing agency eats that risk. What if you, as a service, partner with them instead of competing with them? Right now, you're offsetting their risk. Their insurance premiums go down, their liability risk goes down, their burnout concerns go down, and they pay you for that service, cash money. Right. So all of a sudden you have organizations that are, political enemies, like, oh, that's home health or that's social work. Why aren't we all working together? When again, it turns out we don't talk like that in this profession, right? The CP conference at EMS World in a couple of weeks is going to be fire, EMS, and people who've gone through a CP certification. Maybe one or two people who work with their public safety service. Maybe one or two people who work at a hospital. Right. But ultimately, what we should be doing should be bringing together all these different colors and say, do you guys actually have the same kind of problems? And if you take this, and if you look in Indiana and you go down to Kentucky, or you go across to Ohio, or you go into Chicago, you think these problems are all that different? They're really not, right? The differences are around the edges, right? What do you call yourself? What sort of, how many hours of training? Fine, whatever. But at the end of the day, the programs are really similar. And so we should be doing a much broader view of what works, what doesn't, who got involved, how do we pay for it? And not just the nice shit, right? We need to get into the weeds. What did you spend 2 years banging your head again? That turned out to be a waste. But if you tell me where you got stuck, I can avoid that, right? So it's not just get up in front of people and tell all the shiny happy stories. We need the details. And I can tell you, I have personally been in discussions with people who have basically lied in front of a microphone, and they made everything sound hunky-dory, and you got them away from the microphone, and there was there's all this drama that I didn't tell you about. And I thought, but that's what everyone needs to know.
Right.
So again, I think the economics, I know I laid out a lot of things there. Hopefully people will pause the recording and sort of take down some notes on them, but there are so many colors of money. but it involves getting out of the idea that I'm just going to count the number of dispatches to your house, right? If I see you 8 times in a week or whatever, you're a CP qualified patient. What if it turns out the 8 times has nothing to do with what you're even asking? It turns out this person is afraid to be alone. We saw that in Alameda County here in California. They had they have this different strata of frequent users. There was the high utilizers, the very high utilizers, and the mega users. And it turns out some of these mega users were afraid. They were lonely. They weren't sick. Right? They had some trauma in their history. They were terrified of being by themselves. Maybe they lived in a bad area, right? And so all they really needed was someone to come and check on them on the way home from a hot call, right? You're on the way, I'm gonna blow past you anyway. And it turns out I want to make sure I mention this because that model, loneliness reduction, 300% return on investment, according to the London School of Economics. Checking on people, letting them not feel alone because they live in the middle of the countryside and their grandkids don't come to visit, right? And they don't have, they're kind of by themselves. Maybe their spouse passed. Maybe they don't like their spouse anymore. Right? They don't have anything to talk about, right?
Right.
And so they're lonely. And it turns out that weighs on you, right? You hurt your back. You can't go out and do the gardening anymore. So you kind of loaf around. And we know that that contributes to declining health. But it turns out that having something to live for, even looking forward to a visit from Chief Randell tomorrow at 2 o'clock, by God, I'm going to bake a cake, right? And no joke, it's wild. 3 to 1. You don't need a certification to learn how not to be a horrible person. And there are a lot of things that you could put in there as a colorful word for that, right? But
Right.
you don't need that. Like this idea of when you go take a test on how to go and ask somebody, hey, grandma, how are you? Tell me about your grandkid. Tell me that story again. Tell me about your dog. Why do you call them Bubbles? Whatever it is. I got to go, but I just wanted to check on you. I'll see you tomorrow, right? And if I can't see you tomorrow, I'll call you, right? So remember that story. 300%. What are we doing? Right? Every single community, everyone should have a loneliness reduction program. Special health needs, children with special health needs. But you've probably heard me talk about this. I know of 2 programs in the United States that have a program like that. How is it that every community everywhere does not have a program focused on kids, and some of those kids, if medicine does its thing, will grow up? Right? A program where you could know all of the kids with autism and epilepsy and hemophilia. And how many different organizations are going to be happy to pay you to make sure this kid is safe at school, and the kid, is safe at home, and they don't bolt into the street and get hit by a car? Choose your color of money. The parents will pay you. They're happy to pay you. And if they can't pay you, the church will pay you, right? The local association or whatever will pay you, right? It's as a community action thing. Fire does this all the time. They call it community risk reduction, right? Why are we calling it something different? Just different colors of the same thing. But if you tie a dollar value to that, someone can pay you for it. And they're going to be really happy to, because you can attribute that because you met with this family, and then you met with the local autism society. You made them aware, right? And now you're aware. And they're wonderful emotional stories. I mean, so many of them, of children who have survived, literally lived, because the local responding unit knew what this child's special health needs were. What's the dollar value to that? Every single one of these can be attributed. And so you can take that model and you can find a color of money that would rather pay you to know this child than to have to deal with the ED visit because they got hit by a car and now all their bones are broken. I don't call that preventative care. I call that knowing your community. I call that, I heard Tim Walsh, right? When he, in his speech the other day, I didn't intend to quote this, but I just listened to it yesterday to catch up on some stuff I missed. He called it being a good neighbor. What do fire EMS and CP programs do all day long? Right? They want to keep their community safe, but you can tie that to dollars. And if you haven't thought about that, that's where I come in. Right? I'm the guy who says, all right, sorry, I look like I'm sweating. I'm sorry, I get really passionate about this. But, you can tie every one of these actions to resources. And for all of those resources, they help to do more of it. right? Because if you've done it for 5 kids, you can do it for 15 kids. If you do it for 15 kids, you can do it for the adults that are 40 years old, but 9 inside. And then when those kids are 70 years old and now they have an end of life order, imagine if you knew that. So you didn't resuscitate someone against their will. What's that worth to them and their family and the insurance company and the legal bills alone, right? Every one of these has a dollar value. We don't talk about it. So I do. I talk about it at length, like now.
Wow. I mean, just chock full of good stuff. So if someone wants to get a hold of you, they want to dig deeper, they want to reevaluate their program, they want to start a program, how do they get a hold of you?
So website's real easy. Actually on the screen here, beyondlucid.com. My first name dot last name, so Jonathon.Feit. Be sure you spell it right. It's an O-N at the end.
Okay.
Jonathon.Feit at beyondlucid.com. I'm happy to provide our phone number, 650-648-EPCR, actually, if you want to know. So 650-648-3727. It's kind of an old number there. But we try to be super accessible. We're on social media. I mean, again, I think anybody who follows the controversial threads on LinkedIn probably sees me somewhere in there. We're trying to grab the profession like a snow globe and shake it
Shake it,
every
yeah.
once in a while to see what happens. So LinkedIn, Facebook, Twitter, X, whatever you want to call it. I mean, I believe that we need to have more conversation. So I honestly, my team and I try to lead by example in that regard by being extremely active, right? I mean, you send us an email, we do respond. You go onto social media, we respond. At the end of the day, I think that every program that wants, and I'll be at a lot of these conferences, either me or one of my colleagues, like the EMS World NAMI HP conference, would be there. Speaking at other conferences outside of our sphere as well, trying to make sure we're sort of sharing the love and bringing back insights from other places. But we try to be available because I think if folks want to undertake this effort of building a line of business that they might call CP or MIH or mobile integrated paramedicine, or what do you want to call it, co-response. All of these programs need to be encouraged. We need them. They're wonderful. They're socially great. They're economically very powerful. They're extremely lucrative for a community when done right. So I want to do whatever we can to help get in front of the responder wellness problem, the substance use problem, right? We are seeing programs that are going out to take care of people with real mental challenges, physical challenges, cancer, dementia, and it's weighing on the responders too, right? I don't think we're talking enough about that. We could do a whole show just about the impact there. So our way of kind of living that model is to make sure that if someone says, I want to do this, then I don't care whether you're large or small. I don't care whether you're from rural New Hampshire. We just had a discussion with someone from rural New Hampshire last week about wanting to build a program, or if you're from, downtown major city. If you want to bring this to your community, I want to help you figure out how to do it. I want to help you figure out how to measure it. I want to figure out how to connect you to your ecosystem, so your health information exchange or the national information exchanges, and we want to help you get paid for it so that you can do more of this sacred work. This is as close to our mission as it gets. Again, it goes back to how we started, which you asked. And again, thank you for that wonderful question. But it's all about making sure that the responders are informed. Responders are protected. Responders can show up and, not say, hey, if only, this has really become my hill to die on, Chief, is what if you never had to say, if only I knew, right? If you show up and you knew, what would you do differently? And how would that help you in chronic care management? How would that help you in collaboration? How would that help you in emergency triage? How would that help you after a crash? Right. So there are a ton of places that you can stick this set of concepts to close some really important gaps in our healthcare ecosystem. And I think mobile medicine is that. You're the Swiss Army knife, right? You're the multi-tool.
Yeah.
Do you know the name Josh Parrish from Milwaukee?
I do not know.
So Chief Parrish is just an unbelievable leader. I had the opportunity to interview him a couple years ago. He is one of the leaders in CP in big city environment. And that was his phrase. He talked about, so credit where it's due. He talked about being a multi-tool, right? That this profession is all about you do what you need to do when you get there. And sometimes that's going to be delivering bad news. Sometimes it's going to be, you know, taking somebody out of the vehicle or pulling them off the pavement. But sometimes it's sitting down and saying, "Hey, how are you feeling today?" Right? And that's all part of the toolkit. So I think anything that I can do to help folks um, maximize the use of those tools, because I believe you already have them. If you are the person who runs towards the crisis, you run towards the crash, you pick those people up, you already have what it takes to be a great community paramedic, right? You may need a couple refreshers or maybe some additional skills, like maybe some tests you're not used to running, whatever it is. Those are around the edges. The core of this, the most lucrative programs are what meds are you taking? How are you feeling today? Tell me about your family. I want to give you something to look forward to, and the return on investment, as my 9-year-old son would say. So,
Well,
uh,
that's
happy
good.
to help.
I appreciate that. Hopefully, the folks that listen to this received a lot of nuggets. They have notes, and that they contact you so they can improve their program. I appreciate your time, the chock full of information that you've given to the listeners, and I'll see you in Vegas.
I look forward to it, and thank you for letting me go over time a little bit. I apologize slash not sorry for talking so
Right.
passionately about this.
It's all good. Thanks.
Thank you, Chief.
Thank you.